Good evening, everyone. It's an immense pleasure in welcoming you all for the IPNA Endorsed Webmaster Series 2020. And today we have three eminent speakers, Dr. Soundarajan, Dr. Uma Ali, and Dr. Dechu P Puliyanda. Dr. Soundarajan will be chairing the session for today. Professor Dr. P. Soundarajan is a senior consultant nephrologist at Apollo Hospital, Jubilee Hills, Hyderabad. And it's a great honor to introduce him as well. And he has got more than 35 years of medical teaching experience in various medical colleges. And he has also served as head of the Department of Nephrology for more than 25 years. And he had served as a research guide for many DM candidates and PhD scholars. And to add to his credit, he has got a lot of publications, national and international publications. And he is a member governing council of ICMR, and he is also a member governing body of PGI Chandigarh. He has received the honoris Dronacharya National Award in Nephrology from Avatar Delhi Nephrologist Forum. And he is also a recipient of Lifetime Achievement Award from Dr. Medical MGR University, Chennai. Over to Dr. Soundarajan to moderate the session.
Very good evening and welcome. I think it's my great privilege to take part on this marathon pediatric session going on for the last 3 months. It's a Himalayan effort. I should congratulate Dr. Kalivani Ganeshan for this, and it's gave opportunity to meet our friends like Dr. Umali. Welcome. Yeah, nice to share a podium with you on this important subject of pediatric kidney transplantation today. I think it's Kalivani Ganeshan has done a great job in popularizing pediatric nephrology in this part of the country. It's a welcome initiative. We appreciate you for your efforts. Coming to the subject of the day proper, kidney transplant in children. I think the advances in progress in transplant area and developed world is, especially pediatric transplant, is amazing, astonishing, it's awesome. That's the way I put it. It's of great inspiration to people like us who are interested in the area of transplantation. See what's happening in the Western world is really inspiring for many of us to follow here. And fortunately, such of those centers which have started pediatric transplant, our results are as much comparable to the Western experience. And though the access to transplant is limited to many of the metropolitan cities. With this brief introduction, I go on to my just a brief introduction on the subject. I am sure experts are there to take it forward on specific areas and subsequently. Can I have my slides projected, please? Screen.
So you have to click onto your slides. It's already projected, sir. Just click onto your slides.
Where is that I should do? You told me that. Okay. It is there in the last.
It's next to the video bridge. You have the slides.
Slides. Video bridge, slides. You told me yesterday. Yeah, great. Video bridge.
Next to video bridge, you have the slides column, sir. You just have to go click on to the slides column.
Video bridge, slides column. I should want to that one. Exactly, yeah, got it. I got it. Yeah, sorry. They're all problems of old age, right? We need somebody to help us. Great. Okay. Yeah, my boy is helping me. Okay. Questions. Manage question answer. Where is that video bridge?
No, you have to go up to the slides, sir. On the top of the page, sir.
Yeah.
Manage.
Very correct.
Just above our name list, it would be there, sir.
Yeah, correct. Yeah, above the name list. Yeah, video bridge. Yeah.
Next to video bridge, slides. You have to go click to the slides.
Exactly. Yeah. Okay. Very good. It's all right. We're able to see.
Yeah, it's fine, sir.
Oh, The pediatric transplant, especially, is a difficult and challenging subject. It is difficult and challenging not only for the surgeon, it's also for the transplant nephrologists who do subsequent care lifelong. So many things are common. I remember my medical school days when my professor of pediatrics at the first class, he said, pediatrics is not miniature of adult medicine. It's not a 50% story, 50% of everything of what you do in adults. Or it's not like buying brinjal in the market, putting things in kilogram per kg. So there is especially pediatric transplant. In many ways, it's different from adult transplant. But there are many things which are near identical to adult transplant, especially in the area of drug therapy, pre-transplant workup, etc., etc. But there are a lot of differences in many areas. Obviously, it needs additional and added skills to be learned to become a successful transplant nephrologist in pediatric area. Coming on, the comparing pediatric transplant with adult transplants, many things are the spectrum of etiology to complications are different, immunology to tolerance is different, transplant pharmacology and protocols. I'm sure Dr. O'Malley would highlight on that. I will leave that area to her. And surgical techniques, important, very important, as much as you take care for adult transplant to provide immediate, long-term and short-term results and success story. And there is great survival advantage in children because children live longer, several decades longer than adults. They may need retransplants, multiple transplants sometimes because we have overcome acute cellular rejection and its complications. Still, chronic allograft nephropathy is a still remaining story within long-term survivors of kidney transplant. So this may be an added point in type of patients. So all of us are aware, children are excellent candidates for transplant as they lack comorbidities which are a problem in children. No diabetes, no big diabetes, no big hypertension and such issues which are often found in adult transplant. As you all know, successful transplant improves quality of life, growth and development in children. So obviously the transplant is the therapy of choice for children with CKD5 as per the nomenclature. Transplant in pediatrics is technically challenging because of donor-recipient size mismatch, high risk of vascular complications, and because of difference in vessel size. Drug dosing obviously requires some special consideration, which I'm sure Madam will explain in her protocols, because especially taking into consideration enhancing weight gains over years of growth and variation in drug metabolism and immune responses, which are unique to children. There's obviously high infective complication, especially in the immediate post-transplant period and subsequently compared to adult population. So there is a big, long way to go. This is one of the great problem in post-transplant care in these children is non-adherence to post-transplant medications, which is a common concern, which is most of the time boils down to cosmetic side effects. I know some of my patients who had a transplant, post-transplant obesity, steroids, and they have been ridiculed in the classroom as obese, Cushingoid features, hirsutism, gingival hyperplasia, growth retardations are most of the time main reasons for non-compliance of this type of patients. And see, children, so obviously when they move from pediatric age group to adolescent age group to adolescent renal care, that's a very highly vulnerable period for non-adherence, because they say 60% of drug non-adherence happens in this situation. Patients can end up with complications. So from the last, I'll say I started my career in 1980. Now, when I was a young registrar in nephrology, at that point of time, when we do pediatric transplant, they used to ask myself why do, because so much of complication rate. From why we do transplant from 80s to now we want to why not, because thanks to these advances in the surgical techniques, proper pre-op preparation and immunosuppression, and I think there is no big hesitation to do pediatric transplant in this situation. As you already highlighted, children benefit from transplant physically and mentally. We have a good quality of life. Renal transplant has become the preferred modality and safe in the management of pediatric ESRD patients. And the usual indications are quite familiar to the audience, especially the urgency about and timing of renal transplant in children must be considered in the context of considering number of issues you take into consideration, especially the etiology of the problem, and the delayed cognitive and educational performance, growth retardation and delayed property, and puberty and etiology of ESRD and timing of immunization. So I think there are some special indication than what you will be doing in adult and usual. Obviously, the obvious contraindications all of us are aware, ongoing sepsis and malignancies other than the general fitness for anesthesia and lower tract evaluations, etc. There is a big say about doing preemptive transplant in children because this is one strong indication for especially in our situations where pediatric dialysis is not universally available. Preemptive transplant goes a long way to save the patients from the trouble of going through the complications and hazard. Above all, the spending and transplant dialysis can be saved by taking them for preemptive transplant. Especially, there are a lot of survival advantage if you take them preemptive transplant because there's a normalization of PTH hormone levels. Obviously, it boils down to prevention of short stature and its comorbidity and psychosocial implications if you take them preemptive without going through the agony of going through multiple visits to the hospital for dialysis. So it's also preventive effect on cognitive development related to uremia. And as I said earlier, it's a very cost-effective way. As it says, the cost of money spent on dialysis. So looking at what are the barriers? So looking at the barriers for transplant, this is one of the nice studies quoted in the UK national study involving almost 12 centers out of 13 pediatric nephrology centers. The reasons for barriers are mostly related to basic disease and the lack of donors and organ availability and waiting for the size and all that. These are some of the problems which is to be futuristic, which should be addressed in the course of time. Why patients don't go for transplant immediately, or some of the. This is a scientific study which is published from the Archives of Childhood from 9. These are one of the recent references which I could lay hand on. What about our Indian scenario? As you are aware, the true burden of ESRD in children is not well established meaningfully, though there are some anecdotal attempts for CKD registries in the offing. Undoubtedly, pediatric renal transplant lags behind. I'm sorry to say that. It lags behind in our renal transplant programs. These are predominantly adult-oriented. These are some of the results of publications which are available in the literature, starting from the premier institutes like CNCVLO, AIMS, SCPGI. The largest number has been from Dr. Rizvi's group in Delhi, which is a model for all of us to follow. It's a PPP model where a lot of NGOs are involved. Transplant is subsidized, immunosuppression is subsidized and free. So the numbers are huge. That may be, again, reflecting that the financial aspects of is an important constraint for doing pediatric transplant in this country. Compared to adult transplant program, most of the transplant centers are in metropolitan cities. Most transplants are live donor transplant programs. We can really call it as adolescent transplant program because most of them are 12 plus age transplants and not very young transplants. And the so-called disease donor transplant in pediatric area is really in infancy. It's picking up in several states, especially in Tamil Nadu, thanks to the organ sharing program. I'm sure Dr. Kalivani will take active role in this, bring it up to the limelight in the years to come, right? And the Indian experience is to say, you can see the map, the blue dots indicates mostly the spread of adult nephrologists who predominate most of the time, the distribution of adult nephrologists versus pediatric nephrologists. Red dots are the pediatric nephrologists are mostly limited to the metropolitan cities of Delhi, Bombay, and Chennai, and Trivandrum, probably the south. It's unfortunate, and there is non-affordability is a big problem. And I think we need more trained, committed pediatric nephrologists and pediatric urologists and transplant surgeons to take up the specialty forward. That may be the answer which is needed for the future. The number of, the cost of transplant, as you say, just for it varies from center to centers. And the immunosuppression maintenance cost is again a problem. States like Tamil Nadu are having a subsidized program. As I mentioned, there is a scope for doing retransplant, multiple, because long-term survival is very much better in this time. As I mentioned earlier, children are not small adults. The spectrum of etiology of ESRD in children are mostly secondary to congenital heredofamilial problem, which forms about bulk of cases in contrast to glomerular nephritis and diabetic problems in adults. This technique of transplant is really needs expertise, must be individualized with patient-specific anatomical problems taken into consideration, especially lower tract evaluations, and it is appropriate correction pre-transplant. Really, the transplant's experience and skill matters a lot for obvious immediate surgical results and long-term surgical and graft survival and patient morbidities and survival. And preparation and management of renal transplant in children, especially with the underlying urological problems, requires a thorough understanding of the pattern of bladder dysfunction and its obvious appropriate correction pre-transplant. And it clearly is must be done prior to transplant. Clear strategies for evaluation and treatment before that, and the complications are more or less similar with the immunological complications and non-immunological complications. Metabolic complications are more or less similar to adult transplant. And the immunization issues has to be, all of us are aware, the hepatitis B immunization, vaccination, and all the live vaccine programs, all the immunization should be pre-transplant. Post-transplant live vaccines are contraindicated, as aware. And the issues like kidney size match, I'm sure we'll be dwelling upon subsequently. And viral infection, especially those situations we have faced where we use induction therapies. This is a big problem unless you put them on prophylaxis. And catch-up growth is a big topic which we will be discussing. And once they move on to adult care, this will be an issue which has to be addressed. In terms of patient survival, I think I'll say that excellent pre-transplant recipient preparation and better donor-recipient matching is the secret of long-term success. What it was earlier and what it is today is boils down to the proper surgical techniques and advances in immunosuppression. That goes a long way. So much so the graft survival today is almost 80% at 3 years, 70% at 5 years, and 66% in 10 years. And half-life of renal allograft in pediatric transplant is almost about 10 years is average, as per the literature. This is some of the leading publications from All India Institute of Medical Sciences. Here the results are as much comparable to Western world. Two things are requiring highlight. As I always say, the worst enemy for transplant in this country is severe infection. Infection causes important cause of morbidity and mortality. And the immunosuppressive complication, other things are same as any other developed situation. And there is one more thing is patients require gain significant post-transplant obesity. Post-transplant obesity is a problem even in non-steroid sparing immunosuppressive protocols. Obesity is also a problem. And the final height stature is also, even though they have a catch-up growth post-transplant, still they remain subnormal height when they do that, right? And this is a comparison of over 2 decades of pediatric kidney transplant from various countries, developed nations and developing nations, taken up from one of the recent references, comparing the survival of patients and graft. I think it's all more or less comparable in the current scenario than what it was in the years ago. What about transplants in children less than 2 years of age? This is a very difficult, very interesting observations. This is a study from one of the centers where they have done transplants less than 2 years of age from 11 publications from Minnesota and others. And they say the graft survival of living related donors and recipients less than 2 years of age is better than in the related donor program than cadaver donor programs. Furthermore, graft survival is in children less than 2 years of age is the same as that of older children. That's very encouraging result. I think this is the observation. As much as you do in older children, although the patient survival in younger group may be slightly decreased in this type of patients. So this is a very interesting observation which I got from this. This is various milestones of transplant, which I'm sure which will be very familiar to the speakers. I'm sure the subsequent speakers will highlight on this. From the area of about the surgical problems, I think from the days of handmade typewriters, where we have moved to PCs and whatnot, right? Same thing, young donors were asked to produce, preferred for small kidneys. Gone are the days. Now, size and age matching is generally not required. Smaller children are transplanted via a midline incision into the peritoneal cavity. Kidney can be kept extra peritoneally, or it could be even epigastric, depending upon the size of the child and blood vessels. Renal vein is anastomosed to the side of the inferior vena cava and common iliac, and the arterial anastomosis performed to the side of the aorta and the common iliac artery. The surgical expertise has evolved in a big way to especially younger children. Surgical techniques in children weighing more than 30 kg are similar to adults. 20 to 30 kg, we prefer common iliac for vena and retroperitoneal or intraperitoneal. Less than 20, aorta, vena cava, and these are all surgical points which has also come to play for giving good results today. And especially the mismatch question is almost overcome. I think this is not an issue now. It's comparable. And this is immunosuppressive protocols. I'm sure Dr. Umar is going to touch upon that. Suffice to say that we all old timers, when we started transplants in 80s as a registrar, I think you'll be surprised to know my longest surviving patient, adult, I'm not talking about pediatric, he's only on azathioprine prednisolone for 25 years. It's amazing results. I think that's where we started. More immunosuppression, more induction, more infection, more complications. This is my humble opinion. I'm not subjected to correction. As an old timer, which as you, I have used only azathioprine steroids for, I've seen excellent results doing for 2 decades. I think my longest patient is 25 years. Is amazing. My 35 years of transplant experience. 25 years survival. I think this is a food for thought for so-called non-costly immunosuppression in inductions, etc. I think there is still a scope for well-matched, HLA-matched kidney transplant program to start with lowest immunosuppressions, which will be cost-saving and complication-free. That's my humble opinion. Immunosuppression, I'm sure this will be touched upon by previous next speakers. And the nephrectomies, there are specific indications, I think intractable infection, ongoing sepsis, etc., etc. And this is about infant transplant. This is an important slide which I got from this. I think this, I think less than 0 to 24-month-old children. This is reported from Minneapolis, from the pediatric nephrology group, which is shown that the kidney can be kept intraperitoneal or extraperitoneally. They have shown good results. Adult size graft have been successfully transplanted into infants weighing 7 to 10 kgs. This is very interesting literature which I could lay down, and how they keep kidneys intraperitoneally in young children. It can be also kept extraperitoneally. And these are some of the short-term complications and long-term complications, because once you keep it extraperitoneally, obviously biopsy is going to be difficult, monitoring is going to be difficult. There are some of the simple issues. Long-term complications, which could be comparable to any other transplant situation. I think this is the last slide. This looking at there an association between transplant era. I think we have gone through almost 6 decades, and I am a witness to at least 4 decades of developments in transplant. We have moved from azathioprine prednisolone to triple immunosuppression. Obviously, causes less mortality, morbidity, and there is a success story is obviously related to advances in immunosuppression, which my subsequent speaker, Dr. Amir Ali, will be highlighting. So with that, I say a big thanks and introduce the subject. I'm sure like all of you, I'm also eager to listen to our subsequent speaker. Thank you.
Thank you so much, sir. Thank you for the kind introduction. It was a great introduction, in fact. Soundarajan, sir, can you please introduce the rest of the 2 speakers?
Yeah, it's my pleasure to. I am really happy to introduce Dr. Uma Ali, whom I have seen her engaged at 2 decades back, along with our most of the nephrology conferences she used to come and participate. Dr. Uma Ali is a pediatric nephrologist, well-known name in Maharashtra and Bombay. She started her career well ahead, and she has gone through a lot of contributions, and from the humble position from a consultant to a former dean of children's hospital. She has reputed publications, more than 60. She has received lifetime achievement award from pediatric nephrology group. She has been a life member. Is active participants of most of the. I've seen her in most of the adult nephrology conferences. I think along with it, I think I'm very happy to see her. I'm very happy to listen to her talk on the protocols of immunosuppression. Over to Dr. Uma Ali.
Thank you, Dr. Soundarajan, for the introduction. I'm very happy to be here. Thank you, Dr. Kalaivani. And
thank you.
What I have done after discussing with Dr. Kalaivani of what she would like me to cover, a little, half of the talk would be on how do we look at the child with CKD and what are the things we look at. while we plan that at some day this child may require a transplant. So the planning and preparation start actually much before we reach stage 5 or end stage renal disease. And the second half will be a kind of a look at the perioperative care of these children and the protocols for that. So I would put my plan as a brief introduction, the eligibility and suitability for kidney transplantation, identifying and reducing the risks to the renal allograft, investigating the transplant recipient, peri-transplant management, and conclusion. Now, what we do know about patient survival in end-stage kidney disease is the median survival of an adult with untreated end-stage kidney disease is just 22 to 24 months. Dialysis improves the lifespan, but the mortality on dialysis is 30 times greater than what we see in the general population. So of the options we have, transplantation has the best long-term outcome, both in terms of longevity as well as the quality of life. 10-year mortality has more than halved since the 80s, when it was 14 to 20%, to less than 10% or 7% after 2000. However, even after transplantation, if you compare the lifespan, it is still 20 years lesser than that comparable to the general population. And the main hitch which we have, as Dr. Soundarajan has already told us, that we've managed to handle many of the acute surgical causes, acute rejections, infections, etc. in the acute phase. But the long-term allograft survival, we are still floundering and do not have a right answer. If we just step back and think that despite 60 years of experience in transplant from some of the best minds, best nephrologists, best researchers, and we've come a very long way in our success stories, why do we find it difficult to get an answer, can be viewed a little from a universal perspective. If you see that kidney transplantation is a very idealistic, ambitious, amateur act of rebellion by the transplant team, developed over the last 60 years to counter nature's relentless move, which has been perfected over 1 billion years, to promote its core program, which is survival of the fittest. And what we are trying to do is be humanistic, which is not nature's way, and help those who are unfit to become fit, live longer with a better quality of life. So it is not a well-matched game that we are playing. And hence, if we are in this field of transplantation, we have to give all that we have to it to make it successful. I want to briefly acknowledge the role Dr. H.L. Trivedi played in my life, in my professional life, in mentoring me, initiating me into the field of transplant, and has always taken pride in whatever little achievements I've had and been a great source of support. Now, if we look at the first aspect, that what is the eligibility of the child for kidney transplantation, and is the child suitable for kidney transplantation? Now, every child who's in end-stage renal disease with a GFR of less than 15 ml per minute is eligible for kidney transplantation. So what comes as a barrier is the child suitable? And of these, there are 4 important things. One is the primary renal disease. Second is non-renal comorbidities, which are often associated in pediatric kidney disease because many of them are developmental in origin and are syndromic. And these comorbidities may not be related to the renal problems at all. They are independent problems which a child has. And certain suitability which are temporary and which can be overcome with time. That is the age of the child and the weight of the child. The age is a barrier, a very young infant, which people are trying to overcome. But largely, I would say one would be cautious at a younger age. One, because of surgical challenges which this age poses. And second, because these children are still not immunized against a number of diseases, and to do a transplant very early before immunization is complete is to make them vulnerable to many of the infections which children get as they grow older. And so one may lose a child for infections during this period. So one would rather have a slightly bigger infant who has at least gone through the primary live vaccines, etc., before one considers, even if the center is well equipped to handle such patients. A weight more than 10 kg is generally considered as a weight which is roughly okay for the child to get an adult kidney implanted in the abdomen. As we all know that most transplantations occur with adult donors to children, irrespective of the differences in the body size and the size of the kidneys, which have their own special issues, but have not been a barrier for transplantation to successful transplantation. Most centers in India may not be handling children even 10 kg, because this requires not only a lot of anticipation of the on-table problems, surgical problems, which will be far more than an older child, because of intra-abdominal placement of the organ, intraperitoneal placement of the organ, its effect on the GI tract with ileus, etc. So posing a problem for drug administration, etc., which may occur, and also difficulties in abdominal closure. And so you may have to go with a temporary graft or covering for the abdomen, as well as a higher risk for graft thrombosis. So there are many more surgical problems that come into such a child, and elective ventilation would be often required for these children. And so you would need not just a nephrologist and a good surgical team, but you would need a good anesthetic team and an excellent intensive care services. So unless you have all this and you've had sufficient experience in transplanting children who are older and have got over all those difficulties, it would not be at all wise to go into transplanting smaller children. We are lucky that as far as kidney is concerned, it's not like the liver, and we have a renal support system. And a CAPD can be done even in very small children. So it is quite feasible to tide them over with the dialysis till the size becomes a little less intimidating for the transplant team. One of the very important questions which we have to ask is, does this child have a disease that will recur after transplantation? I'm only briefly touching on some of the important ones, as I feel that each of these topics may warrant a lecture by themselves. Now, there are certain diseases with a high risk of recurrence. One good aspect of pediatric kidney diseases which end up with transplant is all over the world, and as well as in India, more than 60%, 70% of our children who land up with end stage have a congenital anomalies of the kidney and urinary tract, and hence do not have a high risk of recurrence. So that is one good advantage. But having said that, we do have other causes like primary hyperoxaluria, which is definitely not a contraindication for an isolated kidney transplant. And the diagnosis many a times may be missed in older children. And I've heard many presentations where it was identified only when it recurred. So very important is to get a primary diagnosis as early as possible when you diagnose CKD. Unfortunately, in our own data, almost 30% of the CKDs which we have seen, we've died first entry into the hospital has been as an emergency with an acute on chronic end-stage renal disease with a lot of pulmonary edema, hyperkalemia, anemia, etc., etc. So sometimes you lack the time to make the diagnosis. You need to stabilize everything, but one cannot go ahead with a transplant plan without knowing the primary diagnosis and a biopsy, if genetic tests. So there are many options open today to arrive at a primary diagnosis. So there are some which are totally contraindicated to go in for an isolated kidney transplantation. Similarly, if you have an atypical HUS, one has to be very cautious. It's a very wide genotype. So one would need to know what is causing the atypical HUS. Can we identify the gene and the genetic defect? Is it due to factor H antibodies? Is it, etc.? Because they would all have little different kind of implication for recurrence. A post-diarrheal HUS may not pose a big risk, but there is a lot of caution of making a diagnosis of a type of HUS without doing genetic studies. So any HUS who lands up in transplant should have a genetic study done to see what kind of defect this child had, so that we know what to anticipate. Many of them have recurrence risk. So if you have a factor H or factor I disease identified, then they should basically have a combined liver and kidney transplantation. Since we do not have as yet Eculizumab available, most of these are getting transplanted in the developed world because of the availability of Eculizumab, which can be given pre and post-transplant in these patients. Another increasingly recognized entity is the C3 glomerulopathy, which we are seeing, which may be a dense deposit disease or a C3 glomerulonephritis. Again, these have a high rate of recurrence of 50 to 80%. And unfortunately, these recurrences do not have some great therapy which you can offer. Very questionable response to Eclipse, very questionable progress of the disease, and the recurrence does lead to graft dysfunction and graft loss. FSG, as we all know, also has recurrence, but at least has a potential treatment which one can offer. So these are important to decide whether you can go for the surgery, transplant. You have a lot of limitations and cautions and need to discuss greatly with the parents to see if we do have the ability to handle the post-transplant problems which may arise. And immunologically active diseases like lupus, ANCA-positive vasculitis, they do have a risk for recurrence, but if you give some time for the disease to burn itself out, about a 1 year of remission in ANCA, immunosuppression-free quiescent disease in lupus. So if you wait for the right timing for transplant in these children, the rate of recurrence will be less. So each disease has to be addressed according to its own risk of recurrence, the right time of transplant, and a plan for the post-transplant recurrence that may occur. Okay? So the primary diagnosis, I feel, is paramount and sometimes gets missed in so many other issues which occupy our attention. Okay? The non-renal comorbidities are very important in children. And the neurodevelopment takes an important part. The younger the child, it may be more difficult to assess because the renal failure itself may hamper neurodevelopment. And many of these are reversible with good restoration of function, but some cognitive impairments may persist. At the same time, there may be syndromes where there is a true organic involvement of the neurodevelopment. So these have to be teased out to see what is causing, which may not be very easy. Cardiac defects are sometimes accompaniments to renal defects. And so whether they're correctable or non-correctable would play an important part. And if they are correctable, then the timing of that correction, because we have discovered them after the renal failure, all would take a part. Some of the others are GI, liver, etc. And then we should not ignore vision and hearing, which may not be very obvious. To give you just an example, like a child with the Bardet-Biedl syndrome, they have obesity, hypogenitalia, sometimes renal failure. Vision may not be affected at the time we see the child, but it's well known that 100% of them get retinal degeneration and a visual loss. Now, as they grow older. Now, this is not a contraindication for transplantation, But these are things we need to counsel the parents, because Indian parents go to a great extent socially and financially to get the transplant done. So they need to see also what this child is going to face in future and be prepared for that. The second major part we are looking at is to assess what is the risk for the renal allograft, that if we go for a transplant. So you have recipient factors and donor factors. So I'm going to go through mainly the recipient factors today. One we've already covered is the recurrence risk of the primary disease, which we briefly touched on, and we're going to have a lecture later. A hostile bladder, I think this was excellently covered by Dr. Ganesh Gopalakrishnan in one of the things. And so the hostile bladder is an important thing to keep in mind, that we, especially since the bulk of what we see is CACUT, so the bladder needs an evaluation to see if it's a high pressure bladder, poorly compliant bladder, which is a small volume stiff, is going to be a threat to the kidney function and is already partly responsible for the present state. So this bladder evaluation and rectification of these by medical or surgical methods, clean intermittent catheterization, etc., should all be done prior to going in for surgery. So when you go for surgery, the bladder is already well prepared, and the child and the family know how to take care of this bladder with clean intermittent catheterization, and have already been trained in that. There are also a lot of comorbidities that may arise from renal disease, which should be addressed before you take for transplant. We have to look at prior sensitization, infectious risks, and surgical risks. I'll only mention the donor factors. I'm not going to go into that, but we know ABO compatibility, HLA compatibility, the vascular anatomy. If you have 3 renal arteries supplying each kidney, it's going to be a huge challenge for the surgeon to successfully anastomose all these arteries. And so there are surgical challenges. And in disease donor transplantation, donor age, cold ischemia time, the donor creatinine, all that may pose some additional risks and threats to delayed graft function for the renal allograft. Does the child have a safe bladder? I think especially the neurogenic bladder and posterior urethral valves, we need to always look for it. Now, the renal-related comorbidities that need optimization pre-transplant. Anemia needs correction. Hypertension should be well controlled with maybe just 2 drugs and not multiple drugs. Cardiac function should be carefully assessed. This plays a very important role in the pediatric transplant, because you are going to implant an adult kidney, which is much bigger in size and has a lot of perfusion requirements. And this cardiac function has to be adequate to provide the required cardiac output with whatever you may be giving, fluids, etc., to meet the perfusion requirements of the grafted kidney. So children who have low ejection fraction, there's always a question mark of how will they cope with the adult kidney, and need a careful evaluation. Many children, because of poor compliance, inadequate dialysis, etc., often land up with diastolic dysfunction, in which case they do not tolerate fluid, which we may be giving a lot of it post-operatively. And although the heart may improve post-operatively, it does not improve like magic on the same day when you're giving a lot of fluid. So these may require elective ventilation till you're sure that the graft is doing well, and then try deventilating. You need to look for dilated tracts, because they may future become a source of infection. In nephrotic, a very important thing is the hypoalbuminemia and proteinuria. The proteinuria has to decrease, and the hypoalbuminemia has to come back to normal, a good amount of serum albumin, so that the child is not in a biochemically nephrotic state when you take for transplant, because it affects both your graft perfusion, because the fluid doesn't remain intravascular well enough. And also, more importantly, is a big risk factor for hypercoagulable state and high levels of procoagulants. And so nephrotic children, if they are transplanted without adequate preparation in a hurry, are at higher risks of perioperative complications, including loss of graft to thrombosis. Immunizations is very important and has to be completed, including all the additional immunizations which you may give, like pneumococcal, etc. And especially the live vaccines need to be completed because they cannot be given post-transplant. So your MMR, chickenpox, etc. And very important to get good dental care, so the caries, etc., which is so common in children, are all attended to before you take them for transplant. Need to find out whether there have been sensitization events like prior transplants and blood transfusions. Pregnancy is not something we see because we're generally handling children below 18 years. But now with that age increasing, it is something to be kept in mind, if at all. And though other things can also sensitize, but these are the main ones we need to be aware of. Infectious risks are important. Past infections, because they may get reactivated even if they've been treated. Current infections need to be eradicated. The silent viruses which are harboring in the body, like CMV, BV, etc., should be detected by serology and see the corresponding serology in the donor to know what are the risks to the patient. A recipient who has a negative viral serology, who receives a kidney from a donor who's positive, is at higher risk of getting the viral disease after immunosuppression. Surgical risks to be anticipated are prior surgeries, especially urosurgeries, which are so commonly done because the pediatric surgeons do not do pediatric transplants and often do not think beyond the current requirement. And so a lot of what I would call internal cosmetic surgeries for the VUR are done, which do not really change the long-term outcome of the kidneys. And so when you repeatedly handle the ureter and all those areas, sometimes a transplant surgeon, when they enter, see a lot of adhesions, which poses increased difficulty. Renal vessels, I already mentioned. Those who had a long dialysis vintage, especially hemodialysis, we have to be careful because at some point during emergency, the femoral vein may have been accessed. So the patency of the internal, external iliac has to be checked by Doppler to make sure these are all patent. And very important is non-compliance, especially in adolescent children, the older children. Some of them tend to be rebellious and they already sometimes have a lot of family dynamics which are not going well because of the disease. And so if they rebel, do not take, we know that we are going to lose a very good graft and very excellent surgery and we lose the kidney to non-compliance. So this is something that has to be repeatedly spoken to the family, to the child, a plan made for the drug taking and monitored closely. For small children, the ability to take the drugs is important because some of them may not take these drugs well. Some of them are available only as not in solution formulations. And so it becomes very important that to think in advance, how are we going to administer these drugs? In our center, many of our younger children who go on dialysis already have a gastrostomy in place. So we continue using the gastrostomy post-transplant until they become older enough to take all this orally. And that also helps for the liquid intake which you need post-transplant when you shift from IV to oral. A small child may not take that much amount of water, etc., orally, which they may need in the initial post-transplant days. So for younger children, where we are not sure about their likelihood of good oral intake, a pre-transplant gastrostomy, and many of them are prior in dialysis. So at that time, when you initiate dialysis, also doing a gastrostomy makes a lot of difference in their comfort of management. I think this is just putting together what we discussed. So what we would need to investigate is the blood group, viral serology, HIV, HBsAg, HCV, CMV, EBV, tuberculosis, and just before the surgery, you need to be sure that your cultures are negative, urine, exit site, catheter, etc. And you need your blood count, you need your full biochemistry, RFT, LFT, your coagulation parameters, good serum albumin. You also need to know what is the pre-transplant urine volume and urine protein, especially in glomerular diseases, so that you will be able to recognize the recurrence by proteinuria post-transplant. An ultrasound of the existing kidneys, abdomen, and a Doppler were indicated because of prior use of vessels need to be checked. And we already said that voiding should be addressed in all those who have cackled. So ultrasound of the bladder, the uroflowmetry, observing the voiding, and where indicated an MCU and urodynamics are essential before taking up these patients. Cardiac evaluation, lung evaluation, and your HLA typing, cross-matching, etc., looking for preformed antibodies, especially in sensitized patients, are all important for planning your immunosuppression. So at the time for taking for transplant, the child should not have an active or chronic infection, should have cultures negative. If he has an immunological disease, it should be immunologically quiescent. He should have a safe bladder and good bladder emptying practices, compliance with medications and fluid intake, and should not be actively nephrotic or hypoalbuminic, and have a good control over hypertension. Does the child need nephrectomy? I think this was already addressed. Some of the common indications, this may not be a full list, are large polycystic kidneys which are space occupying, and hence a new kidney cannot be placed, or have already had a lot of problems like hematuria, infections, etc. because of the cyst. Kidneys which have stones in them because they form a nidus for future infection. Past infected kidneys like pyonephrosis, severe hydronephrosis, etc. Sometimes uncontrolled hypertension. Most of the times hypertension with good fluid control and one or two antihypertensives is under good control. But sometimes for various reasons, the hypertension may be uncontrolled, and some of these may require nephrectomy. And one important reason is a nephrotic who has a severe ongoing proteinuria. One may try a medical nephrectomy when they are undergoing dialysis, but sometimes that may not be enough, and one may have to go for a bilateral nephrectomy so that the proteinuria is removed, the albumin levels return to normal, and one can remove some of the other risk factors which you may have. I think the cornerstone of perioperative management is our ability to maintain graft perfusion through maintaining the right blood pressure and fluid therapy. This is a big challenge in pediatric age groups, especially in younger children, less of a problem in adolescent children whose size often is not very different from the donor kidney size. But if it's a 5 or 6 year old and the donor is the father who's 40 years old and he's, a well-built gentleman, there's a huge discrepancy in the kidney sizes, and he may be the only donor we have, so we don't have much choice in the matter. So to maintain the graft perfusion, one needs to target the mean arterial pressure of the donor and not of the child, and give adequate fluids to maintain both the pressure and the MAP. And sometimes this may need even the addition of some inotropes. This is intraop. The second part is our attempts to prevent rejection by immunosuppressive medications, preventing infection, thromboprophylaxis, and very close monitoring. So what we do have is we have drugs which we use what we call for induction during the time of surgery, immediately on the day and subsequently immediate post-op. And induction medications are generally used to give you two benefits. One is your immediate immunosuppression. So because when you're first time facing such a big antigenic load and an exposure to the circulation of the new antigens, you're sufficiently protected. And it might enable you to use subsequently lower levels of steroids, etc., in your subsequent management, and prevent the immediate risk or early risk of acute rejection. The two most widely used drugs which we have are the IL-2 receptor blockers, which is Blisselumab, which are monoclonal antibodies. And so Blisselumab is basically acting by one of your chief attackers are your T cells when they recognize something as being foreign to the body. And so it blocks the IL-2 receptor and kind of immobilizes the T cell from activating the downstream elements which will promote T cell proliferation and the generation of cytotoxic T cells which can kill the kidney. The polyclonal antibodies, on the other hand, are stronger. They are T cell depleting agents. They kill the T cells. So you have anti-thymocyte globulin, and the most widely one is the rabbit ATG, which is used. Maintenance drugs are your CNIs, either tacrolimus or cyclosporin, your anti-proliferative drugs, which is either mycophenolate or azathioprine, and steroids. The choice is made somewhat individualized, because you have to decide whether this child is of low immunological risk. Luckily for us, most pediatric patients which we see are the first transplant. They've not had a previous transplant, but they could have been inadvertently sensitized by blood transfusions because they're looked after many times by pediatricians initially, who may not be aware of the risks. And so they may be given blood for anemia, which could have been managed without blood transfusion. But if they are low immunological risk, meaning they're not sensitized patients, they don't have preformed antibodies, and you have a good HLA match, then induction with IL-2 receptor blocker is probably the choice. The limiting factor with us is the cost. It's quite expensive in India. And there are several, although now induction is almost universally recommended for initiating therapy, up to almost 25 to 30% of centers in UK may not be using an induction therapy in low immunological risk patients. So that is one thing to keep in mind. And the triple immunosuppression most widely used today is tacrolimus, mycophenolate, and steroids. Children with low immunological risk, one has an option of steroid minimization or withdrawal, provided other factors are favorable. As opposed to that, those who are a high immunological risk may require more potent induction agents like ATG. The dosage used varies widely variant from center to center, but the recommended doses totally are about 6 mg per kg or a little more, but many centers use a much lower level in India, along with triple immunosuppression. And if you're high immunological risk, you would not attempt steroid withdrawal. Okay. Infections, important is to know the CMV status of donor and recipient. A donor negative, recipient negative, you don't need CMV prophylaxis. Both donor and recipient positive, you need a prophylaxis for 3 months with valganciclovir. And if donor is positive and recipient negative, which is your highest risk, you might need it for 6 months. Usually prophylaxis is not given for bacterial infections, just the peri-op antibiotics, which may be there for a few days, except for urinary tract infection. But since we give for PCP, to avoid PCP pneumonia, we are giving cotrimoxazole. It generally also covers for your UTI, so you don't need to additionally give. Something which we cannot prevent, but which we need to monitor, especially in the first year, is BK virus. So the recommended protocols are something which we are unable to follow in India, because it's every 2 weeks for first 4 months, and then every month, etc. And because the test is costly, it's not possible to do it that frequently. So one has to devise a protocol to suit us where we do it at least 3 to 4 times in the year and see if that is sufficient. Fungal infections in the immediate perioperative period, you need like nystatin, a locally acting fungal infection to prevent GI tract colonization. I think come to the last few slides. For the peri-op fluid therapy, pre-operatively, we need to avoid fluid overload to keep your lungs dry. But we also need to avoid hypovolemia. Many children might need a short dialysis the day before to keep their potassium electrolytes all in range. And this has to be done without heparin and without removing much fluid, because you don't want to keep the child volume depleted and more prone to hypotension and poor graft perfusion at the time of surgery. So they need to have adequate hydration before they go for surgery. I've already mentioned our intraoperative goals. Target the MAP, target a good CVP, because when you release the clamps after anastomosis, an adult kidney kind of takes in almost 250 to 300 ml of blood. So there is a big drop in your circulating volume, which can cause severe hypotension, and also graft perfusion may be compromised, child may be compromised. So this turns out to be one of the biggest challenges when we are managing small children who are undergoing transplantation, that the intra-op management has to be very tightly done to maintain good perfusion throughout, especially focusing on the time of clamp release and subsequently. Okay, so fluids are generally targeted to CVP and MAP. Preference is given nowadays to balanced solutions than normal saline because of to prevent hyperchloremia and its attendant vasoconstrictive effects, etc. And after release of clamps, when urine output starts, the urine output sometimes is a very large amount. So urine output should be replaced volume for volume to prevent hypovolemia to develop subsequently. So the usual monitoring is a lot of it clinical, hourly urine output, so that you replace volume for volume. When the urine output is large, we replace it every 30 minutes. So the first 24, 48 hours is slightly toxic. Blood pressure monitoring, because you want to maintain an optimal blood pressure. You don't want it too high, and you don't want it to go below the map of the donor. Keep the lungs dry. So it's a very conflicting thing that you're trying to hydrate the kidney, but you're trying to keep the lungs dry, and everything that depends on good cardiac function and good urine output. Watch for line infections, drains, wound sites, etc. You need to have an ultrasound and Doppler of the transplant kidney to make sure that it's perfusing well. And if you encounter any drop in urine output, that needs to be done also urgently to recognize early graft thrombosis, which is a very small window for intervention. Blood counts, creatinine, electrolytes are done frequently, almost at least twice a day minimum. And calcium, phosphorus, magnesium maybe once a day. Urine routine culture daily. Watch for proteinuria and glomerular disease. And CNI levels are monitored frequently to get the right level that you want. And finally, I'll focus that for a better outcome, there are 5 things we need to look at. We need to optimize the long-term function of the first allograft. What people have said, like in India, you have one marriage and you have one transplant. You don't have more than that. Second transplant, many people don't come forward for. So the best is your long-term function of the first allograft, which you need to be very careful in your choice and your preparation. Promote living donation to reduce the waiting period and the problems related to dialysis. Specifically important in pediatric age group, because pediatric dialysis is practically, something exotic present in only few cities and in a few centers. So preemptive transplantation should be a goal for pediatric transplantation, unless there are limitations to it. early allograft injury. So close monitoring, which may be twice a day or thrice a day in the early period, daily afterwards, and then twice a week, etc., as time passes by. Because the time for action for an allograft injury is actually yesterday. It's not today or tomorrow. It's already happened. So you need to be on top of that. And we are hoping that there will be better therapeutic interventions for a better outcome. So all those pediatric nephrologists who plan to be transplant physicians need additional training, need to work in a center to get the required experience. And in their practice, they need to allot a significant time of their practice for dedicated transplant practice, because pediatric transplantation eats up a lot of your time and attention. It cannot be kind of handed over to some resident or somebody who's going to look after. They may not be able to take the decisions, and one needs to be over there available very easily. And I would say you need to have little nerves of steel, because it is quite stressful. Every transplant is different from the other, and every patient behaves differently from the other. So you always seem to be learning and never have learned fully. Thank you.
That's an excellent discussion and overall view of pediatric transplant. Took us through the journey of entire spectrum of do's and don'ts meticulously. We are thankful to you, Madam Dr. Mali. We'll have the questions posted in the box.
Sir, we'll take the questions towards the end of the session, sir, because we have one more speaker.
Yeah, sure. We'll take up the questions at the end of the session. True.
Yes.
We'll go on to the next speaker has joined.
Yes. Yes, sir.
Yeah, welcome. Welcome, Dr. Dechu P Puliyanda. We have a great pleasure to welcome you to our prestigious forum today. We are so lucky to have you. Looking at your biodata, you have an excellence in teaching, research, and patient care. Rightly, you have been awarded. You have a special interest in CKD and morbidities, and special interest on transplant biomarkers and transplant in highly sensitized patients. We love to listen to you to how to go about in preventing and managing recurrence after pediatric transplant. Over to Dr. Dechu P Puliyanda.
Thank you, sir, for that very, very kind introduction. And I just want to give a shout out to Dr. Kalaivani for putting up with all my technical difficulties this morning and bearing with me as we, fix our my computer and etc. Morning for me, sorry, evening for y'all, dinner time for y'all. So I will make sure that this goes by just highlighting on the important topics. I know that I've discussed many cases with several of you, but I'm again opening myself, in case I can be of any help to any of you, please reach out to me. Dr. Kalaivani has my WhatsApp number as well as my email. And so I would love to brainstorm with you if you have any difficulties with patients, especially in terms of the subject that I'll be talking about today, which is recurrence of disease post-transplant, how to diagnose and manage. Dr. Uma Ali, thank you for that excellent talk, has set the stage nicely for, for me to go about this talk. She also mentioned a few things which I'll be sort of elaborating on in the talk. One of the things that two of the things that I want to highlight what she mentioned is one, each of these diseases that are associated with recurrence is a talk in and of itself. Trying to cover all of this in like a 30-minute window is difficult, but I will try to do my best. Again, I'm definitely open to questions, and also after the session's over to brainstorm with each of you on your difficult patients. The second thing that I think what she said was so important, and I keep telling this to our residents and fellows, is you have to have nerves of steel if you want to take care of transplant patients. I think that, I show my gray hair and say, well, most of this has come from taking care of these difficult transplant patients. And I think all of you who manage transplants can, very, very boldly show off your gray hair, because a lot of it has come from managing these transplant patients. So without further ado, let me go ahead and get started here. So the objectives will really be to discuss diseases that can result in recurrence post-transplant and the graft outcomes for these diseases. Again, Dr. Umali has mentioned those diseases. I will also be talking on how to recognize disease recurrence, because that's important, so you can trigger early management. We'll talk about treatment of recurrence, and then we'll just gently touch on differential diagnosis of this recurrent disease post-renal transplantation. So the glomerular diseases that recur post-transplant, there is a long laundry list of these diseases, starting from HUS, starting from FSGS actually, atypical HUS, C3GN, membranous nephropathy, IgA, lupus, anti-GBM disease, ANCA vasculitis, and primary hyperoxaluria. My focus will really be on FSGS, but I will talk about all of the other diseases, but heavily on FSGS, because that is something that comes up very often, even though, the risk of recurrence of other diseases also is pretty high. So this is the risk of recurrence of primary disease, and it shows you that steroid-resistant nephrotic syndrome with FSGS, the recurrence rate is about 30% with 40 to 50% graft loss. And then when you go all the way down to primary hyperoxaluria, sometimes the recurrence rate is as high as 100% with 80% graft loss. So, and the other diseases, there is a smattering of disease frequency and graft loss. So with FSGS, thankfully, like Dr. Umali said, most of the cases of primary transplants are from K-cut, which is congenital anomalies of the kidney and urinary tract. FSGS accounts for about 12% of children undergoing kidney transplantation here in the US, and I'm sure the numbers are pretty much the same in India as well. The overall risk of recurrence is 30%, but the not so gratifying thing is that the recurrence risk increases with each successive transplant. The most common cause of graft loss, it is the most common cause of graft loss due to recurrent disease. And unfortunately, the risk of recurrence is greater in children than in adults. And you can see 86% in children versus 35% in adults. So the risk factors that have been looked at for recurrence are the age. Again, there is a little bit of controversy, and I'll show you another slide on this, but typically the age at presentation, and if it's associated with steroid resistance, is a very high risk for recurrence. Rapid progression to ESRD. So I think that's why age comes about there, but really the rapid progression to ESRD is more important, because if you have a diagnosis and the diagnosis quickly progresses to ESRD, the window between presentation and start of dialysis or start of ESRD, that window is the time. And if you progress rapidly in that window, then the disease recurrence occurs much more. There's a higher percentage of disease recurrence in those transplants. Some people have looked at histology, and histology showing diffuse mesangial proliferation may be associated with higher risk of recurrence. But one thing I think we all know is that if you have mutations in genes encoding podocyte proteins, they appear to have a very low risk of disease recurrence. And so a lot of centers do genetic testing prior to transplanting these patients. We don't routinely do genetic testing unless there's a reason to believe that there may be a genetic component to it. We are not doing it in 100% of our patients who have, FSGS and who go in for transplant. So the recurrence of nephrotic syndrome according to the age of onset, and you'll see here, this slide is a little more, it's controversial compared to the previous slide that I showed you about age. Here it shows that age greater than 6 years with 54% disease recurrence. This is from one of the centers in France. But I think that going back, I think much more than the age, it is the time from diagnosis to ESRD and that time window that actually results in a higher risk of recurrence if that window is small. So how one make a diagnosis of recurrence? Recurrence most often occurs after the first few days after transplant, but it can occur even months after transplant. One of the very troubling features of FSGS is sometimes it can occur within a few hours after transplant. I remember transplanting a child whom I knew was at high risk for recurrence, who got a cadaver kidney. And we finished the transplant at midnight, and we were going to start plasmapheresis by like 6 in the morning because I wanted to start preemptive plasmapheresis, which we'll talk about. But the first protein to creatinine ratio that I did before starting plasmapheresis was already at 40. So the child was losing 40 grams of protein within the first 6 hours after transplant. So this disease is very, very, can be very, very dramatic at its presentation. So I think we just have to have a lot of, open-mindedness in order to believe that the disease can recur at any time and be ready to start treatment in these kids. And proteinuria is the first sign of recurrence, and treatment should be initiated immediately. I think that the crux of how you would manage these patients with FSGS is to assume that these patients will have recurrence and try and do everything possible in order to prevent recurrence of the disease. So the couple of things that we do, and again, looking at literature, are Dr. Umali talked about induction. These are the patients in whom you would consider using Rituximab or pre-transplant Rituximab if it's a living donor. If it's a cadaveric donor, induction with Rituximab at the time of transplant would be very important in these patients. Also, some centers have been using IV cyclosporin. Typically in our center, we've avoided using IV calcineurin inhibitors because of the risk of nephrotoxicity in a fresh allograft. Continue to use Prograf, but there are some recommendations on using IV cyclosporin. What about pre, peri, and post-transplant plasmapheresis? So if you have the luxury of having a living donor transplant, then you can consider pre-transplant plasmapheresis in these patients. A lot of times these are cadaver kidneys that come to us, and so we do not have the time to do pre-transplant plasmapheresis. We initiate early onset post-transplant plasmapheresis in these patients. There is also a question of native nephrectomies. We had written a paper about this in the past. I think the reason to do native nephrectomies would be more to because of the heavy proteinuria that you have, and because you cannot effectively transplant a child with that much proteinuria for a couple of reasons. One, because you need good albumins going into transplant, and the second reason is because when you have to look for recurrence, you would not know whether the proteinuria is coming from the native kidneys versus the transplant kidneys, and therefore native nephrectomies would be considered in these patients. There are a number of other trials that are ongoing. I just touched upon some of the medications that we use, and I'm happy to share protocols and such, but I just wanted to mention that there is a big trial that actually, when I talked to the primary investigator yesterday, they had actually completed the enrollment. It's an adult trial where they had 60 adult participants. So besides what we know that we can use in FSGS patients, like rituximab, IV rituximab, plus or minus IV calcineurin inhibitors, pre, peri, and post-transplant plasmapheresis. The other drug that is actually being considered is this drug called Blisselumab, which is like those who have heard of abatacept, which is a co-stimulatory blockade. This drug is similar to that drug in that it blocks the T cells from actually going forward and presenting to B cells and initiating recurrence of the disease. And this was a randomized open-label active control multi-center trial to assess the efficacy of that in the de novo kidney transplant with high risk of recurrence for FSGS. So stay tuned for the results of the study. I think once it comes about, other centers will have to sort of validate what's going on with the study, but at least there are some newer drugs that I wanted to show you that are in the pipeline. Again, just showing you where these drugs act. Sorry, let me go back. So to show you where these drugs act, here is a slide that actually shows you a T cell and an antigen presenting cell, and the abatacept and the belatacept act up top here at the co-stimulatory blockade area, and the Blisselumab acts more on the CD40 ligand. And as we know, these two are co-stimulators in terms of downstream events causing rejection and perhaps even causing recurrence of FSGS. So just to kind of tell you a little more about treatment options, we have early institution of plasmapheresis, which is definitely very important. Consideration of Rituximab also is extremely important. There's another drug called obinutuzumab and its relative ofatumumab, which are cousins, if you will, of Rituximab. This was a paper that actually came out first in the New England Journal and was published from India by Dr. Basu's group in Kolkata, looking at Rituximab-resistant FSGS, not in transplant patients, but in before transplant. We have actually used this drug in our post-transplant patients if they have been resistant to Rituximab, and we've had 2 patients who have actually come off of plasmapheresis completely and who have low-grade proteinuria that's being managed with ACE inhibition and so on. And so this is one of the drugs that definitely needs to be considered for patients with recurrent FSGS that are resistant to Rituximab. Acthar is another drug that is, it's a melanocortin stimulating receptor inhibitor, and these melanocortin stimulating receptors are present on the podocytes. And so Acthar is one of the drugs that is similar, but not quite the same as prednisone, and it can be given as a subcutaneous injection. And there's a lot of literature to suggest that this drug may actually prevent ongoing recurrence of FSGS. Lipoapheresis is sort of the new kid on the block, if you will. We have the ability to do lipoapheresis. The mechanism of action is thought to be removal of these bad actors, if you will, of FSGS, most importantly, the circulating factor, much more than what is removed with plasmapheresis. So there has been some success with lipoapheresis, and actually there are 2 ongoing trials in pediatrics here in the United States. So the next disease is, I'm sure I've not covered 100% of what I would like to say for FSGS, but for the sake of time, I just gave you the main highlights. And like I said again, I'm happy to discuss individual difficult patients with you all. Happy to brainstorm, and if you reach out to me afterwards. So atypical HUS is something that you all commonly see. We see it as well, and it's associated with risk of recurrence. That is quite high if it's atypical HUS. There's a risk of recurrence of 50 to 80%, with 90% risk of graft failure. But as you all know, the typical HUS, the risk of recurrence post-transplant is less than 1%. So most of these patients don't even go in for transplants. They do pretty well. Pre-transplant, it's at the onset of the disease, but it's the atypical HUS patients who don't do too well. And complement antibodies are the cause of atypical HUS in about 8 to 10% of patients. And so doing plasmapheresis pre and post-transplant followed by immunosuppression is key in these patients. So depending upon their mutation, the risk of recurrence actually varies. The highest risk of recurrence is with the CFH and the IF mutations that cause a very high rate of recurrence, and as you can imagine, a very high % of graft loss as well. So again, this is a slide showing the genetic variants in the treatments with plasmapheresis. Some of the genetic variants respond much better to plasmapheresis than others, and this gives you a smattering of the treatments and the response to plasmapheresis based on genetic variants. We this is again, a slide that, I don't want to belabor the complement pathway. The minute you say complement pathway, people can just zone off. But I just wanted to show you this slide because the two very, very important treatments that have come about for patients with atypical HUS is what blocks the C5 downstream effects from the C5 pathway, which is eculizumab and ravulizumab. So MAB, as you all know, standing for monoclonal antibody. So these monoclonal antibodies actually target the C3 pathway going into the C5, and the C5 causing its deleterious effects. And so blocking these pathways in atypical HUS is of paramount importance. Again, this is slightly a busy slide. The eculizumab used for kidney transplantation in patients with a diagnosis of atypical HUS. This was a study that was, this was probably one of the biggest studies that was done. It's actually from a registry of 188 patients. And what they saw was that delayed diagnosis of atypical HUS and delayed treatment with eculizumab post-transplant leads to inferior outcomes. I'm aware that it's not very easy to get eculizumab in India. We are hoping that the other drug, the ravulizumab, which is a subcutaneous form of the eculizumab, may be cheaper and maybe more user-friendly in patients in India. And stay tuned. I'm sure that this is going to be the next wave that's going to be coming up there. So the one thing that you have to know about these monoclonal antibodies is they increase susceptibility to infections, especially with encapsulated organisms, and therefore these patients should be vaccinated against Neisseria meningitis at least 2 weeks prior to them receiving the transplant. If you have to do a transplant urgently in a patient with atypical HUS and the patient cannot be vaccinated, you can administer the vaccine. It's not a live vaccine, so you can administer it as soon as possible. But in the meantime, provide patients with 2 weeks of antibacterial drug prophylaxis. And here we tend to use ciprofloxacin. The vaccination reduces but does not eliminate the risk of meningococcal infections because the pathway of controlling Neisseria meningitis goes through the C5, and blocking it increases the risk of developing these infections. So the biggest problem with these drugs that we use for atypical HUS is there is kind of no stop line for when you can actually stop these drugs. And so, and these drugs are extremely, extremely expensive. And so, some of the bigger trials are looking at when can you actually stop it? Should you wean it? Can you stop it cold turkey? Can you stop it suddenly? So the eculizumab and its sister drug, the treatment of atypical HUS, it is said it should be for a minimum duration of at least 6 months with monthly infusions. Again, no specific data on discontinuation. After discontinuing treatment, if you ever discontinue it, patients should be monitored for clinical symptoms and laboratory signs of thrombotic microangiopathy complications for at least 12 months. The TMA complications post-discontinuation can be identified if any of the following are present. The first thing that you would see is thrombocytopenia, and because of cell breakdown, increase in LDH, of course, increases in serum creatinine, and because of the thrombotic microangiopathy, in the brain, you can see mental status changes, seizures, angina, dyspnea, thrombosis, increasing blood pressure. All of those signs and symptoms should point to the disease coming back again and reinstitution of therapy. So moving right along, Membrano-proliferative glomerulonephritis. Again, the classification, as we all know, has gone back and forth, but C3 glomerulopathy belongs to this big category of patients as well. Luckily, the primary diagnosis is only in 2% of our pediatric patients requiring transplantation. It's pretty rare, but the risk of recurrence is about 20 to 30%, again, higher in children than in adults. The younger age and diagnosis and presence of crescents on biopsy are independently associated with recurrence. We've gone through this whole name game and learning about where each disease falls into this into specific categories. But there is a significant overlap in terms of these immune-mediated glomerulopathies. The C3 glomerulopathy is sort of one of the big things that we've learned in the last several years, where there's a predominance of C3 deposits in the glomerular basement membrane. And this is now got this new term called C3 glomerulopathy. Again, very high risk of recurrence. Again, they are all complement-mediated diseases. And so treatment, again, because they're complement-mediated diseases, is to try and target the complement pathways. Eculizumab has been used in these patients with variable clinical outcomes. So looking at the complement inhibitors, there are several. So the three big pathways of complement activation are classic pathway, the lectin pathway, and the alternative pathway. And all of them meet at the C3, and all of the downstream effects are seen from C3 to C5 and downstream of that. And so there are many complement inhibitors that have been targeted in several different diseases. But for us, since C5 seems to be sort of the main pipeline, if you will, that causes the downstream effects, these two drugs, the eculizumab and the revolizumab, have actually been pretty useful in kidney diseases. What about membranous nephropathy? Again, the incidence of membranous nephropathy is quite small, especially idiopathic membranous nephropathy. This is something that's seen a lot more in adults than in pediatrics. Sometimes we see membranous nephropathy in the setting of lupus, and that's sort of a different entity, but idiopathic membranous nephropathy is associated with this anti-phospholipase A2, anti-PLA2R receptor autoantibodies. And so the risk of recurrence is higher if patients have these autoantibodies. And you can actually test for these autoantibodies. And I highly recommend that this test be done in order to predict the risk of recurrence post-transplant, because patients who have these autoantibodies are at higher risk. If you cannot do it in the serum, before the serum test became available to us, the pathologists were, up to speed on their game, and they would actually stain the biopsies for the anti-PLA2R autoantibodies and tell us whether they stain positive or not. That's another way of actually also looking for these antibodies. The recurrence is manifested, of course, by proteinuria, and the histology actually confirms the diagnosis. There have been very promising results with the treatment with Rituximab, both for prophylaxis and treatment of membranous nephropathy, and luckily Rituximab is easily available in India and therefore can be used. What about IgA nephropathy? Again, the risk of recurrence is about 20%. However, the histological recurrence is sometimes more common than actual clinical recurrence. So what does that mean? So when you do a biopsy for looking for rejection, sometimes you can see IgA deposits in the kidney, and these don't necessarily mean that there is clinical recurrence. Sometimes it just means that this is histologic recurrence. And so if you find IgA deposits along with all of your changes of T-cell mediated rejection, treatment of the T-cell mediated rejection will actually reverse the disease progression in and of itself. Sometimes it's hard to determine whether this is histological recurrence versus clinical recurrence. And so it's best to treat as if there were clinical recurrence. So if you look at the graft outcomes in the IgA patients versus the non-IgA other GN patients, the graft outcomes are similar up to first 5 years post-transplantation. If we do see proteinuria, we almost always start with ACE inhibition. If they are 3 months post-transplant, we tend not to use ACE inhibition within the first 3 months post-transplant, because changes in serum creatinine might lead us to think that this is rejection. We also, alter immunosuppression in order to prevent recurrence or curtail recurrence if it's starting to happen. Lupus nephritis, again, not very commonly seen in the pediatric population, but in general, people with lupus do well after a kidney transplant. This might be because we use the same immunosuppression that is used to control lupus. So it's almost like, killing two birds with one stone. The immunosuppression helps us, reduce the risk of lupus recurrence and therefore its impact on the kidney transplant. What about anti-GBM disease? So anti-GBM disease, as you know, is a direct attack on the glomerular basement membrane in patients who develop this disease. They progress, they're rapidly progressive glomerulonephritis. If it's associated with lung manifestations, it's called good pasture syndrome. The one thing that you have to remember when you transplant patients with anti-GBM disease is that they will not have a recurrence of anti-GBM disease in their graft. However, they can develop Alport's syndrome in these, the patients with Alport syndrome can develop anti-GBM disease when you transplant patients with Alport syndrome because they're missing that that particular collagen that's present. And so when you transplant these patients, that the collagen is given because the new kidney has that collagen, and therefore there's an attack from the recipient onto that new collagen, and so they can develop anti-GBM disease in these patients. I think it's much more of a theoretical risk. We've transplanted a number of patients with Alports. We've always suspected anti-GBM disease, but actually have never seen it. Sometimes when you do a biopsy, you might see a little bit of linear staining, but that doesn't translate completely to a disease in and of itself. And I think also because we treat these patients with immunosuppression, that perhaps prevents anti-GBM disease from coming up in these patients. And if they do come up, plasmapheresis is the treatment of choice. Only for anti-GBM disease, you transplant only after the anti-GBM titers are negative for 1 year. The recurrence rate, like I said, is quite low. It's less than 5%. If they do present with recurrence, they present with rapidly progressive glomerulonephritis, and plasmapheresis is the treatment of choice for these patients. What about ANCA vasculitis? The dictum for ANCA transplant is you have to transplant only when the ANCA titers are stable. Again, the ANCA titers may not always be negative prior to transplant, but as long as they remain stable in low titers, you can go ahead and transplant these patients. The recurrence of P ANCA vasculitis is very low, but recurrence of C ANCA vasculitis, which sometimes is associated with Wegener's, is 15 to 17%. They usually present with hematuria and rapidly progressive glomerulonephritis. And the treatments are plasmapheresis followed by Rituximab are the treatments of choice for ANCA vasculitis. Primary hyperoxaluria, again, is a talk, all by itself. I'm going to mention it here mainly because I'm talking about disease recurrence. And, recurrence of these oxalate deposits in the graft is constant, leading to graft failure. The best approach to prevention is to do a combined liver-kidney transplantation, even though a small subset of patients may get away with just kidney transplantation. That's a little more rarer, but you can prevent recurrence 100% if you do a combined liver-kidney transplant. If you're going to do just a kidney transplant, make sure these patients are dialyzed extremely well before you take them for transplant because, the disease recurrence is pretty high. And chronic pyridoxine treatment in patients who are pyridoxine positive needs to continue even post-transplant. Sometimes preemptive liver transplant prior to the onset of renal failure is a strategy to avoid the need for renal transplantation itself. So some of my last slides are actually talking about the differential diagnosis of recurrent disease after kidney transplant. There are so many things that are happening after a kidney transplant that you don't know whether this is disease recurrence, whether this is a de novo glomerulonephritis, especially membranous, which can happen, whether this is chronic rejection, cyclosporin toxicity, acute rejection, whether there's just allograft ischemia, CMV infection that like was previously mentioned, or because the proteinuria is from sirolimus therapy if you are planning to use sirolimus in your patients. So just paying attention to what all the differential diagnosis can be, and sort of eliminating the differential diagnosis before you actually start treatment for these patients is really, really important. So in conclusion, always obtain an exact diagnosis of the original disease whenever possible. One of the things that we find a little difficult is to tease out primary FSGS from secondary FSGS, because primary FSGS is a high risk of recurrence. Secondary FSGS that happens because of other native kidney diseases is not associated with disease recurrence or FSGS. It's very hard to determine that. Sometimes your pathologist can be of help, because if you see a lot of chronic interstitial nephritis and FSGS, then the original disease may be chronic interstitial nephritis. Sometimes we sit down with our pathologist and go over a lot of different aspects of the pathology itself in order to determine. If you have a family history, then it's less likely to be primary FSGS. There's more than likely a genetic cause to it. So obtain exact diagnosis of the original disease whenever possible. Always look at the native kidney biopsy. Sit with your friendly pathologist to tease out, what else could be going on in the native kidneys. Closely follow patients peri and post-operatively for abnormal labs, and institute therapy early. The very, very simple test to do, of course, is the urine analysis at every visit. And if you start to see proteinuria, then you're starting to look at perhaps recurrence of the disease. Do a biopsy if you want to tease out the other differential diagnosis. So early diagnosis with biopsy, both for routine immunofluorescence and electron microscopy, is very important. This is probably my last slide. So the risk of recurrence post-renal transplant, as I mentioned before, is highest for FSGS and steroid-resistant nephrotic syndrome, whether you have a biopsy of FSGS or not. Anticipating recurrence and measures taken to prevent it may be advisable. So looking ahead is key in these patients who undergo a transplant. Proteinuria and or hematuria, the key presenting symptoms, followed by decline in kidney function. So our urine analysis is very, very important. Biopsy is almost always needed to make the diagnosis of recurrence, as there are other diagnoses that can be possible. Graft loss especially is very high in patients with FSGS, and maintain a very high index of suspicion and monitor for disease recurrence, because this can present at any time after transplantation, as early as a few hours to as late as a few months to years. There's no specific therapy for disease except for FSGS and atypical HUS, but there are a number of clinical trials in the pipeline. I just mentioned one of them. So hopefully we'll have good therapy in the future. And these new monoclonal antibodies, it's the wave of monoclonal antibodies at this time. And so these might be like disease targeted and disease specific, and may change the incidence of graft loss from recurrence. Thank you so much, and be happy to take any questions after the forum, or if people want to, message me separately, that's fine as well. Thank you very, very much.
That was an excellent delivery on the subject, Dr. Dechu Puliyanda. I think Dr. Kalaivani should give you another award today for your excellent talk on the subject.
Thank you so much.
I think it's excellent. I think very heartening to hear about there is something going to come cheaper than Eclipse-mab, the Blisselumab subcutaneous form cheaper. I think before you go into the chat box to look at the questions, I got a question to ask you about the so-called the prevention of FSGS, the preoperative Rituximab. What about the recent thinking about the role of anti-Rituximab antibodies? Do they play any role, any adverse roles in the outcome? Anti-Rituximab antibodies.
Yes. So, I think anti-Rituximab antibodies are so much more theoretical than what we would actually see in clinical practice. I think, between you, Dr. Soundarajan, Dr. Umali, and myself, we've used a lot of Rituximab. And I've been, again, in practice for about 20 years now. I really have not come across patients who've actually developed anti-rituximab antibodies. They're not, even though this rituximab is chimeric, we've not seen the development, which is very, very gratifying because we've been able to use several doses of rituximab to prevent recurrence. So it may be much more of a theoretical risk than we actually see it in clinical practice.
Thank you. Thank you.
Sir, there are questions in the chat box. Can you read out the questions, sir?
Chat box.
Yeah.
Just you can
The
wait for
question and
me.
answer session.
You can pass on to this chat box. Yeah.
It is there on the question and answer session. Next to auto refresh, you can put it in the full page if you tap onto the orange highlighted one.
Can we also see it, Kalaivani?
You can read it for me. Yeah,
I'll read it for you, ma'am. I'll do it for that. Okay, sir. The first question is, what ejection, I think this question is being directed to Dr. Uma Ali. What ejection fraction is suitable for kidney transplant?
See, I think that's $1 million question because generally as a rule, at least 40%. But having said that, I offhand remember at least 2 patients where the ejection fraction was barely 20%. And after a long discussion with the parents and with other nephrologists, adult nephrologists for their experience, it was finally decided that perhaps their only chance of survival would be doing a transplant, and that if you continued with dialysis, probably they'll worsen cardiac-wise. My concern was with the ability of the heart to pump enough for the graft perfusion, besides having anesthetic catastrophes of myocardial depression or something. But surprisingly, I don't know, both of them withstood the surgery well, and post-op the graft was perfused well, and they did, both of them have done well. But many literature cautions about taking less than 40% and sometimes less than 30%. So I think these are a high-risk group where you have to see what is feasible. Both those, we took like a high-risk consent for death on table and explained the possibilities which could happen and then took.
Okay. And the next question is, in what situation is anti-thymoside prescribed?
Generally, it is recommended for high immunological risk patients. But I think it is also in many centers being used as the primary induction agent for various other benefits which they have felt. And it is very, the use in India is very varied, you know. It is used as an induction agent frequently by many nephrologists because for us it is much cheaper than Blisselumab. Okay? And many of them in this low-risk patient use ATG as a single intra-op infusion and not continue it later. So I think there's a quite wide variation in which different people, maybe they will be able to tell us whether these are valid uses or what.
Yeah, it's very interesting, these the protocols for induction therapy at different centers, and it's I was very surprised to hear that Blisselumab is more expensive than ATG because that's the opposite over here. But having said that, though, use of ATG, as an induction agent is very widely used. Especially, I'm seeing it in India more than over here. Here, we use it mainly in our highly sensitized patients and in our steroid-free protocols. But the way that it's used is very different. So in India, if you're having a low-risk patient and you want to use an induction agent, the default is using ATG. And the way they use ATG is not by giving, like you rightly said, just a one-time dose. of ATG of 1.25 to 1.5 mg per kg as a one-time dose, as opposed to what you would use for highly sensitized patients or what you would use for steroid avoidance patients, where you would use, 4.5 to 6 milligrams per kg per dose. So there's a whole wide range of using it, but it's a great induction agent. The only thing is, I'm sure all of you face this, it has a big propensity to cause leukopenia, needing for adjustment of your MMF dosage and so on downstream, and also very closely monitoring for viral infections.
Thank you, ma'am. And the next question is from Dr. Jyoti Sharma. Thank you for this lucid talk. And the question is, for how long do we need to target a map of donor in post-op period?
I think it's primarily during the intra-op period, and maybe for the first 24, 48 hours when, this is essentially a denervated kidney, so it doesn't have its own good autoregulation. So it is very pressure dependent and pressure passive. So maintaining the pressure is important. It's not a very big problem in bigger children because their normal pressures match the adult pressures. But we face problems when we've taken this thin, skinny children who are 6, 7 years old and slightly underweight, and their normal BP is 90 by 60. And we are trying to get them to 120, 80. I mean, we've had problems there. One of getting those blood pressures, because we have to use some vasoactive agents to keep it for some time. And second, some of them do not tolerate the higher pressure CNS wines. So I find that I'm more scared of somebody who's normotensive and getting a big adult kidney than a hypertensive kid getting that kidney. Can I ask you one question, Dechu? What about no induction?
Yeah. So, this was actually studied by the Nephrotics, North American Pediatric Renal Transplant Collaborative Trials. You probably are all familiar with it. That's our big database from which we gather data. They found that about 22% of centers in the United States do not use induction. And I think that, when you compare no induction to induction with Blisselumab, the results are pretty much the same. The risk of rejection, everything is pretty much the same. So I think a lot of us believe that Blisselumab is a very, very weak, if you will, induction agent. I think a lot of us, when we use Blisselumab, we are more than anything comforting ourselves that we've used induction agents, but it's not a potent induction agent by any stretch. And so because of that data, a lot of centers are not doing induction immunosuppression, which is fine. I mean, if you have a well-matched kidney, and if you do, your methylprednisone, which is also another induction agent, by the way, as your, perioperative immunosuppression, that is actually plenty if you have a well-matched kidney. So for the low-risk patients with well-matched kidneys, you can get away without using Blisselumab. I'm not talking about ATG, but definitely get away without using Blisselumab with using high-dose methylprednisone.
Most of our patients are one haplotype match because it's a parent who's donating, mostly the mother. Sometimes the father.
Yeah, in those instances, using just 1 to 2 doses of ATG is a good induction. You probably don't need to use much more ATG than that. I think it's so much better than Blisselumab. One of the reasons to use ATG, in my opinion, is you don't get adequate prograph levels immediately post transplantation, and you're relying only on steroids. So giving ATG will give you that long, at least for a couple of days, before you can actually have good prograph levels. And then your MMF absorption is so poor post-transplant because of, some amount of ileus and stuff. So getting all your other immunosuppression up and on board while your ATG is acting. So giving 1 or 2 doses of ATG is plenty for your 1 haplotype matched kidneys. In fact, just even 1 dose is enough for those patients.
The use of ATG for induction, we end up giving routine CMV prophylaxis mandatory.
Yes, sir, absolutely, because we have seen CMV viremia pretty commonly with thymoglobulin induction, much more so even with, we use over here alemtuzumab induction for our patients who are highly sensitized. We've seen that ATG giving rise to, even though alemtuzumab is supposedly a more potent immunosuppression, we've seen CMV much more so with ATG than we have with alemtuzumab. But I think the good thing is that you see you have to monitor them carefully. And if you see CMV viremia, just adjustment of immunosuppression will curtail the viremia. They usually don't have CMV disease, and they develop CMV antibodies, which is good because at least in the future, you're not looking at pretty bad CMV infections. So monitoring them for the first 6 months after transplant, even under cover of valganciclovir, these patients can develop CMV viremia. Yes, it's a well-known complication.
And the next question is from Dr. Chandrasekhar from MGM. He's asking, like, a growth failure after a successful kidney transplant, what do we recommend? Umali madam or Dechu madam, who would like to take the question?
I think Dechu, you may give us an answer for that.
No, great. I'm happy to take that. Usually, you should not see as much growth failure if you're telling me it's a successful kidney transplant. So the reasons for growth failure after a successful kidney transplant is more than likely, because of some steroid use because of a lot of steroids that you're using. We wait for 1 year before we start patients on growth hormone therapy if we continue to see growth failure after transplantation. And we do see a lot of catch-up growth afterwards. But again, if you see growth failure after a successful kidney transplantation, go ahead and look at other factors that could be causing growth failure. One of the things that I mentioned is high-dose steroids. If your steroids are still at significantly high doses, try to see if you can wean the steroids down to like the much maintenance doses. The other thing you can do is to try and see if you can slowly wean them to every other day steroids, which is much more effective. There have been papers that have been published that show that there is very good growth with every other day steroids as opposed to with everyday steroids. These papers came out of Boston, actually. This was many, many years ago when I was doing my fellowship. We were involved in the studies. So every other day steroids is important. Make sure that these patients don't have GI problems with the use of MMF. A lot of these kids are very sensitive to MMF, so their appetite is decreased. And so make sure that you adjust the dose of MMF or put them on some kind of H2 receptor blocker to help with that. If they are still having decrease in appetite, we start a lot of these patients on some appetite stimulant like periactin and stuff like any appetite stimulant. Should not be using trade names here. So any appetite stimulant. So make sure that you've addressed all the issues that might lead to growth failure. If they have proteinuria, that can also lead to growth retardation. So addressing all of those things in the first year, and then if you've addressed all these things, then going on to use growth hormone, we wait till the end of the first year to consider growth hormone would be something that you can do. Yeah. I hope that answered that question.
Yeah, yes, ma'am. The next question is there a donor age limit for pediatric kidney transplant? Umali, madam, can you take up that question?
No, I'm passing on the question to Dechu. Is there an age limit?
The donor, are you asking about lower limit of donor age or upper limit of donor age? So those are,
lower limit.
Lower limit, exactly.
I think it must be lower limit.
Lower limit. So the cutoff, it's more of a surgical issue because, the vessels are so small and you can very quickly thrombose these vessels depending on whom you transplant it into. So for us, the cutoff is if the donor is less than, this is our cutoff, and of course, different centers make their own cutoffs. This is just because of how comfortable a surgeon is using those kidneys. So if a donor is less than 12 kilos, then the surgeon will do en-bloc transplant. So they'll take both the kidneys from the donor in order to place into the recipient as an en-bloc transplant. En-bloc transplants in pediatric patients is a little dicey. Again, it depends on whom it's going to. So if you're trying to do an en-bloc transplant from a small donor into a small recipient, that's a very, very dicey thing because first of all, there's no room, and second of all, the vessels are all too small. All the vessels that you're anastomosing into are too small. But if you're thinking about doing an en-bloc transplant into an adolescent or almost like a young adult donor, that is a possibility. So we usually don't give like lower limit cutoff globally because it depends on whom we are transplanting it to. So if you're transplanting it to a bigger person, an adolescent, then en-bloc transplants are feasible. But if you're transplanting it to a smaller recipient, then we don't want to do en-bloc transplants. So again, it's the comfort level of the surgeon and who the recipient is who's receiving these kidneys.
And the next question is post-Eclipse. It may be renal limited TMA, which will need graft biopsy to pick up. How often have you seen renal limited TMA?
Yes. The times that we've seen renal limited TMA is not so much with atypical HUS as we've seen it with other causes of TMA like calcineurin inhibitor toxicity. We see really bad TMA in patients who don't tolerate calcineurin inhibitors, and that is totally renal limited. But when we've had patients with atypical HUS, the TMA is usually sort of in a more global way. We see thrombocytopenia, and those are all the presenting manifestations. So in my experience, renal limited TMA is mostly seen with non-AHUS primary disease as opposed to AHUS primary disease. Does that make sense?
Kumari, madam, do you have anything to add on?
No, not really, because I've not really transplanted any HUS patient, very frankly. So
okay, fine. And the next question is, what is the chance of recurrence in mesangial-proliferative GN?
So mesangial-proliferative GN is like this big bag of diagnosis, right? Like I showed you, the whole immune complex GN is almost mesangial-proliferative GN, and they go by very varied names. If it is a C3 predominance, they have a higher risk of recurrence than if they are not C3 predominance. So that's what it depends. So your pathologist needs to tell you whether this is a major time C3 GN versus other forms of mesangial-proliferative GNs.
Okay. And the next question is, if the first graft is lost due to recurrent FSGS, how would your protocol change for the second transplant? Or would you advise against it, especially live donation?
Excellent question. In fact, a day before yesterday, we had a patient, because our center does a lot of highly sensitized patients, and that's my big thing. We were referred a patient who had lost his first graft from very bad recurrent FSGS, and so is coming to us with not only being highly sensitized with 100% PRA, but also with a double risk of recurrence of his FSGS, in his second transplant. So in those kind of patients, we have to be very aggressive pre-transplant for both dealing with the high CPRA as well, high PRA versus, and also preventing recurrence of FSGS in the allograft. Luckily, the treatments are the same. the treatments are the same. So we would do plasmapheresis prior to transplant. We would do IVIG and Rituximab prior to transplant. And then at the time of transplant, if the patient is on the operating table and has Rituximab, more than a month early, we would give another dose of Rituximab as an induction agent on the operating table, along with our other induction agents. And we would continue them on post-transplant plasmapheresis for at least 7 sessions before we stop plasmapheresis and see what they do in terms of recurrence. Again, like I said, luckily, plasmapheresis, IVIG, Rituximab are our protocols for highly sensitized patients. And so it's the same thing for prevention of recurrence post-transplant. So thankfully, we can kill 2 birds with 1 stone by doing that kind of a protocol. But we are always, keeping other agents available to us. We have a very low threshold to start these patients on obinutuzumab, like I mentioned, and also starting these patients on lipoapheresis if their recurrence, continues despite plasmapheresis. They are tough patients. They're very, very tough patients.
Okay. And the next question is, how do we diagnose disease recurrence clinically in primary hyperoxaluria?
Well, the patient becomes anuric. That's almost the first thing. The urine output falls dramatically, because what happens in primary hyperoxaluria when they have recurrence is that the entire kidney is flooded with calcium oxalate crystals. So you won't have a urine output, so your urine output drops dramatically. That's one of the first signs of recurrence. And if you were to do a biopsy, it's completely loaded with calcium oxalate crystals. So that is what you will see with primary hyperoxaluria. It is not subtle. These patients, their recurrence is not subtle. It's not like a little bit of proteinuria and you're wondering what's happening. No, they go from, having a fairly good urine output to just very dramatic, drop in urine output. And if you do a biopsy, the whole kidney is flooded with calcium oxalate crystals.
And so the next question is, do you always do nephrectomies in pediatric patients with hypoalbuminemia and nephrotic syndrome, as we don't do that in adults?
Yes.
What is your comment on that?
Correct. Thank you so much for that question. I think that alluding to what I said before, it's very important to distinguish primary FSGS from secondary FSGS. In adults, what you see as FSGS a lot of times is secondary FSGS, secondary to really bad hypertension, secondary to chronic interstitial nephritis, secondary to, a lot of different conditions that can happen. And if it is secondary FSGS, first of all, the risk of recurrence is almost nil. Second of all, these patients with secondary FSGS, they do not have rip-roaring proteinuria as patients with primary FSGS do. In pediatrics, you all know, we see primary FSGS, their protein to creatinine ratio is very, very high. They lose about 40 grams of protein in 24-hour period. There is no way you can take a patient like that for a kidney transplant without doing native nephrectomies. So the bottom line is, if you have a patient going in for transplant who has FSGS, maybe you don't know whether it's primary or secondary, but has, a protein to creatinine ratio that is, around 1 or a loss of 1 to 2 grams of protein, and you're completely sure that's coming, that's what you're having from the native kidneys. And your albumin is reasonable, like it's greater than 3.5 grams per deciliter. Those are the patients who do not need native nephrectomies because you have a pretty good baseline starting, so you can transplant them and see what happens. So proteinuria doubles from where it was at baseline. If their albumin falls, then maybe you're looking at risk of recurrence. But for the patients, the younger patients with primary FSGS who have such aggressive proteinurias, even though they have lesser and lesser urine output, they have very aggressive proteinuria, and their albumin is extremely low that you have to keep giving albumin infusions. And they have very bad hypertension as well. I think those of us who've taken care of these primary FSGS patients know they are on 3 or 4 antihypertensives. These are the kind of patients who definitely will benefit from native nephrectomies for a number of reasons. Your proteinuria is under control. The other thing that I'll tell you is, if you have patients with primary FSGS and they have proteinuria and you check their titers of the vaccines, which we do for all of our patients, they've all received, varicella vaccine, MMR vaccine, but you check their titers, it's dismal, it's negative. You cannot take them for transplant with no immunity to varicella, no immunity to measles, mumps, and rubella. However, you cannot vaccinate them prior to transplant because of their reporting proteinuria, their IgG levels are so low, they're not going to mount an immune response. The only way to vaccinate them and to get their titers to be good is to do native nephrectomies and to stop their proteinuria and to build up their IgG levels. So for a number of reasons, you should consider native nephrectomies for these younger patients with FSGS, primary FSGS. And it's not that important in the older patients and the adults because I don't think you're checking for immunity in those patients. They're not at high risk for like chickenpox and measles and mumps and rubella and stuff like that. And usually the older patients, their proteinuria is not as bad and their albumin levels are reasonable. So I think they don't need native nephrectomies.
Yeah. Yeah. Next question is, what is your take on avoiding Blisselumab in low risk? Thinking the cost ratio. Is it okay to avoid in low risk patients Blisselumab?
Totally. I think we just talked about it. I think that, if Blisselumab is more expensive than ATG, and knowing that Blisselumab is a pretty weak induction immunosuppression agent, and it's been proven that, no induction versus Blisselumab induction, there is no increased risk of rejection. You can totally avoid Blisselumab and probably do, like we talked about, 1 dose of ATG or maybe 2 doses of ATG, depending on what kind of a match you have in these patients. Sure.
The next question is, do you monitor CD3 count before the next dose of ATG?
No, we don't. So if you're asking whether we monitor CD3 counts, but CD3 counts were important when we actually used OKT3. CD3 counts are not as important when you use ATG because it's a much more global rather than OKT3 when we use ATG. So there is no reason for you to monitor CD3 counts when you use ATG at all, especially when you use it in succession, like, you do 3 doses or 4 doses or whatever number of doses, keeping the max as 6 milligrams per kilogram. If you use it consecutively, you don't need to monitor CD3 counts.
Okay. And the next question is quite a long question. How do you manage drug-induced, that is CNI or mTOR inhibitor-induced TMA in post-transplant period? And if native disease is unknown, how safely can you differentiate from a possible native disease as TMA? Do you consider re-challenge reintroduction of CNIs if response to therapy is seen?
Very, very, very good question. So like we talked about, the way to know whether you're having a disease recurrence TMA versus knowing whether this is because of CNIs is really by looking at all of your other parameters. So we talked about this, renal limited TMA. So usually you'll see renal limited TMA with CNIs. If it is atypical HUS causing TMA, you will definitely see all of the other myriad manifestations. You will see, thrombocytopenia, much increases in your LDH levels, all of them suggestive of a systemic thrombotic event that's going on, as opposed to with calcineurins when it's mostly in the kidney. We have seen this in 2 patients who were completely, for want of a better word, allergic to calcineurin inhibitors. Every time we started them on either cyclosporin or tacrolimus, their creatinine used to shoot up, 3 biopsies all showing TMA with calcineurin inhibitors. In those kind of patients, you have 2 choices. Number 1, you can use a combination of sirolimus and Celcept, and MMF, sorry, I shouldn't use the word Celcept. So you can use a combination of sirolimus and MMF. But if the patients are EBV seropositive, you can consider the use of the drug called belatacept. Again, I'm not quite sure if it's available in India. It's a CTLA-4 Ig. It's a wonderful drug. You can consider monthly use of belatacept, and that's what we did in our. So the first patient, we used the combination of sirolimus and Celcept. And the second patient, because he was EBV seropositive, we used belatacept. Belatacept is a very high incidence of causing EBV viremia, and risk of PTLD is very high. So it is not indicated in patients who are seronegative for EBV, but you can definitely consider it for patients who are seropositive for for EBV, and you can use it as a monthly infusion in these patients. So those are the two possibilities to entertain in patients who are very CNI, can be very CNI toxic. Yeah.
Okay. Great explanation, ma'am. The next is not a question, rather a comment. Many adult nephrologists say Blisselumab is just like water, rightly said by Dr. Dechu. And the next question is, are Indian children tolerate TAC poorly? In the sense they are probably CYP2 polymorphism because they get toxicity even at a very low dose. 2 of our patients are now at 0.75 twice a day dose with the TAC levels of 4.75 and biopsy showing TAC toxicity. I think it's more like a comment. Would you like to explain anything on this question?
I think it's a common experience. So generally our TAC doses and TAC targets are at the lower end of the recommended. And often we use much lower dose than what you would for the initiation of transplant. And, they do quite well with the lower doses. And when you try to achieve the level suggested in books, in fact, they land up at toxicity. So this is, I think, almost every person dealing with transplants and nephrology in India has a similar experience as far as TAC dosage.
Yeah, that's very true, ma'am.
Yeah. Maybe I should ask.
Yeah.
Yeah, ma'am. Yeah, sir. Yeah, tell me, sir.
Yeah, you lost a kidney due to BK virus nephropathy, unsuccessfully treated. Okay. You want to retransplant the patient. What precautions you should do? You should do a nephrectomy?
No need, sir. Sir, there's no need to do a nephrectomy after losing a transplant to BK nephropathy. There are several papers that have been published in this regard, and we have transplanted a number of patients who lost their first kid to BK nephropathy. The nice thing, sir, is that, once you develop BK antibodies after the first BK viremia and BK nephropathy, the risk of having BK in the second transplant is extremely low. So you do not need to remove the transplant unless you continue to have BK viremia even after the graft is lost. Sometimes there is low-grade viremia in these patients, and for some reason the body is not able to curtail it, and that might be an indication. But otherwise, you can very nicely proceed with desensitization and transplant for the second time without actually doing a transplant nephrectomy. Can I also mention, sir, that we would prefer that you don't do a transplant nephrectomy because the incidence of developing donor-specific antibodies and antibodies is much higher when they've had a transplant nephrectomy than when you leave that transplant kidney alone and leave them on like low-dose immunosuppression. So the indication to do a transplant nephrectomy for BK nephropathy is almost not there, sir.
Thank you.
And the next question, we just have 2 more questions. Is it okay to take up, sir? It's already late. Is it okay to continue with the questions? We just have 2 more questions.
I'm fine. It's dinner time for you all, so I'm fine.
Uma, madam, is it fine?
Yeah, I'm fine. Go ahead.
For non-FSGS patients, biopsy proven with nephrotic syndrome and around 4 grams proteinuria and 2.5 serum albumin can be gateway without nephrectomy.
what was the first sentence? In non-FSGS? No.
Non-FSGS patients, biopsy proven with nephrotic syndrome and around 4 grams proteinuria and 2.5 serum albumin, can we get away without nephrectomy?
So there are, again, several questions. What is the IgG level? Is this patient's titers of all your immunizations, are they adequate? Is the patient having malignant hypertension? Is the patient growing with an albumin of 2.5? Are you having to give multiple albumin infusions in order to prevent the patient becoming, overly edematous? So those are all the questions that need to be answered before you can decide on native nephrectomies versus not. Does that make sense? Whoever asked the question?
Yeah, it really did.
We have had a few patients where with ACE inhibitors and continuing dialysis, they've gradually become anuric and built up their serum albumin. And we've taken them then for transplant. The maximum time this takes is about 4 to 5 months. But many of our patients are okay with it because they take that much time to decide about transplant and arrange all the logistics and everything. So while that is happening, we do like a medical nephrectomy. I won't say it works in all, but it has worked in a fair number. So we've got away without the nephrectomy because by the time they reach the time for transplant, there's hardly any urine output and the serum albumin has built up close to 4.
Yeah, totally agree with Dr. Omani, really. But, you find a lot of patients, even though their renal function is so bad, their BUNs are in the, 80s, 90s, 100s, their creatinines are like 8, 9, 10, they're still making substantial amount of urine and we're losing a lot of protein despite ACE inhibition. So in those patients, you get into a bind as to, what you want to do. So that's when these native nephrectomies come into consideration.
Okay. And the next question is, how do you manage low TAC levels and subsequent evaluation showing AUC adequacy versus inadequacy? Do you consider switching to cyclosporin in such cases?
Is this a question for me?
Yeah, I
think
we don't do AUCs, we just do trough levels.
Correct. So that's the first thing that I want to say. I mean, it's incredible that you all do AUCs. What we've actually seen is the tacrolimus AUCs differ based on the manufacturer of tacrolimus. So, I don't know who is the manufacturer for tacrolimus for you and whether you can consistently get it from one manufacturer. If that's the case, it's great. But over here, because we've all gone generic, there are at least 10 different manufacturers of tacrolimus. And when we switch from one manufacturer to another, we get very different changing trough levels. That's one thing. The second thing is patients who are on liquid tacrolimus have very erratic, trough levels and perhaps AUCs if you want to do AUCs. So those are the kind of patients in whom we've considered using tacrolimus granules, which give us a much more consistent, trough levels in these patients. I don't know if switching to cyclosporin is the answer. I would say that if you're getting it from different manufacturers, trying to see, in other patients who've had a consistent manufacturer, what trough levels you're getting, may be the way to go in those patients, because cyclosporin has its own bag of side effects. You will, even with cyclosporin, sometimes it's hard to get very consistent levels, trough levels in these patients. In fact, the AUCs are better with tacrolimus than with cyclosporin in the studies that were done previously looking at AUCs comparing cyclosporin to tacrolimus. So I would say that, try a consistent manufacturer. If they're on liquid, try granules, and, see if you can get away with that.
Okay. How do we decide on reintroduction of MMF after BK ban requiring discontinuation therapy?
BK is a whole another bag of worms and topic for discussion. Would love to do a talk on BK, but so I guess it depends on what have you done to actually take care of BK besides discontinuing MMF. So if you discontinued MMF, but instead of MMF, you've had leflunomide that was used, which I don't know if you all do or not. Then the reintroduction, the way we do it is we cut the leflunomide dose by half and add half dose MMF. And we leave that going both on leflunomide and MMF for a month. And then the next time we just take off leflunomide and increase the dose of MMF, so that you're actually keeping some leflunomide on board while you're, introducing your MMF. But be careful because, the introduction of high doses of MMF, if you've just gotten a negative BK viremia, and if you get to the entire dose of MMF, then you might have resurgence of BK. So the introduction needs to be slow, and that's the way we would do it, at least over 1 to 2 months. While keeping leflunomide and reducing leflunomide, you increase your MMF. But if you've done cidofovir as your, medication to curtail BK, which is not done a whole lot. I'm not sure what your protocols in India are. We do not use cidofovir. We've gotten away with the use of leflunomide and the use of, reduction in MMF. We don't know which works, but it works. If you've used cidofovir, if you've had 3 negative BK PCRs that you've gotten, then you can introduce MMF 30%, 60%, and 90% over a 2-month period. Be very careful because, if you've discontinued MMF and you've not used any other immunosuppression, you're looking at the development of donor-specific antibodies. So be very careful when you do that. Yeah.
Great, ma'am. We are done with all the questions. I'm very happy that there are so many attendees who are so interested in asking so many questions about transplant and disease recurrence. Thank you so much, Soundarajan sir. Thank you so much, Umali madam. Thank you so much, Dechu ma'am. It was really a mind-blowing talk, and I learned quite a lot of new things in this talk. Thank you so much.
Thank you for giving me the opportunity to be with you all.
Thank you, Kalaivani. Thank you, Dr. Soundarajan.
Thank you, Dr. Soundarajan, too.
Thank you. Thank you, all of you. I think we should love to invite her in person, both of you, to India again after the epidemic is over. Right? We should visit us.
Would love to be there. Dr. Umali knows we go back more than 20 years. I love to be in India every time I get an opportunity. So yes, definitely.
Great. Nice. God bless you. Thank you.
Thank you. Thank you so much.
Thank you. Thank you so much, sir. Thank you, ma'am. Thank you, Dechu ma'am. Bye. Good night.
Bye. Good night. Yes.
Good night.